Good morning. I'm Dr. Tavish Gupta, and I'll be speaking on navigating optic neuritis secondary to breast cancer treatment. So, we're presenting a 41-year-old female with diminution of vision in the left eye, which was sudden in onset, and it 1 day ago, and it was associated with pain on ocular movements. There was no history of trauma, no history of headache, and no other positive history in the patient. She had a significant systemic history in which she was diagnosed with breast cancer in January of 2022, for which she underwent a breast conserving surgery and lymph node biopsy, which was followed by radiotherapy treatment and chemotherapy treatment. And currently, the drugs the patient is on is the TAP gabapentin. On examination, the right eye was within normal limits, but in the left eye, the visual acuity was 6 by 36, and the color vision and contrast were also reduced in the left eye. The pupil showed a relative afferent pupillary defect in the left eye, and on the fundus picture, we can see that the left eye there is disc edema present, and it's a unilateral disc edema, and the right eye is normal. So, considering the history of breast cancer in this patient, we looked up some reports and we found that metastasis to the optic nerve can present as optic neuritis in such patients. So we further investigated the patient. First, we did a visual fields testing in which the left eye showed a focal visual field deficit, and then we went on for a contrast enhanced MRI of the brain and orbits. We wanted to look for tumor cells in the we wanted to look for optic nerve thickening in the CE-MRI, which would show that there is metastasis to the optic nerve. But we did not, but in the MRI, we found the typical findings of optic neuritis only, in which there was T2 hyperintensity along with fat stranding, which was present. And there was no other evidence of metastasis seen anywhere else in the brain. Now we went on for a CSF analysis to look for tumor cells in the CSF, which were absent, and there were no and all the CSF findings were all normal, including the infectious test for infectious disease as well as the CSF protein and glucose. As part of the routine panel, we did blood investigations also, in which we were surprised to find that the anti-MOG antibodies were strongly positive in this patient, which is quite rare. Now, for and as we did not find any metastasis and we found an optic neuritis with an anti-MOG positive antibodies, we started the patient on intravenous pulse methylprednisolone, which was given 1 gram for once a day for 5 days, followed by oral prednisolone 1 milligram per kg. And with this, the patient improved with the best corrected visual acuity of 6 by 9, and the color and contrast sensitivity also improved. And in the on the fundus CP also 1 week later, the disc edema is resolved. Now the discussion. In the beginning, we thought it's a unilateral vision loss. So from the history, it could be due to retinal detachment, central retinal artery occlusion, optic neuritis, or a non-arthritic ischemic optic neuropathy. But due to the characteristic pain on extraocular movements, which was later confirmed on imaging also, we diagnosed it as optic neuritis. Now, why is this atypical? Because the patient has a history of cancer also, and she has undergone chemotherapy also, and drugs such as paclitaxel which are used, they may also cause they are also known to cause optic neuritis. But in this case, the atypicality was due to the MOG positivity, which is again quite rare. So the cause of optic neuritis in patients of breast cancer can be divided into oncological causes and non-oncological causes. The oncological causes is the most important one, which is the metastatic involvement of the visual pathway and the optic nerve, in which the thickening of the optic nerve is seen, or we'll see tumor cells in the CSF. It can also be due to the ocular toxicity to paclitaxel and other chemotherapeutic agents used in breast cancer chemotherapy, and due to the radiation related side effects. But not we should also consider the non-oncological causes and take a detailed history and investigate for any toxin-related optic neuritis, or due to a B12 deficiency, or if it's due to a multiple sclerosis, or due to an infectious disease also, as we saw in this case. So in conclusion, breast cancer related optic neuritis is quite rare, and most of the cases which are reported are due to metastasis to the optic nerve. And it is quite important to look for optic nerve thickening, as metastasis to the optic nerve will indicate that there is metastasis following the breast conserving surgery, and it will further guide our treatment. But we should also see for other causes of optic neuritis in such patients, as early detection of the optic neuritis due to other causes, such in this case such as MOG antibodies, which has not been reported before. And in this case, the early detection with the prompt administration of steroids helped in preserving the visual acuity of the patient. Thank you.
What about the oncological causes you have shown?
Yes,
That
sir.
is, one is the metastasis, and other two is the ocular toxicity due to the
Chemotherapy.
treatment and the radiation therapy. But it was unilateral.
Yes,
So
sir.
the last two causes, it's ruled out. So only can be it's the metastasis. There was no metastasis because
Yes, the patient actually had a presentation of 1 day, so it might be a delayed it could have been a delayed bilateral also because we.
let me just finish. So
Yes,
it
sir.
was not metastasis.
Yes, sir.
So oncological causes, whatever the causes, it's ruled out. So
Mm.
can it be just coincidental?
Yes, sir. That might also be there, and it might be coincidental also. It might be due to the stimulation of the autoimmune system of the patient due after the breast cancer therapy also, which has not been studied before, will need future study.
Should be bilateral.
Yes, sir.
Nice presentation. I like the way you put your thought process over there about causes of decrease of vision. I just had this one point. I don't know, maybe it is for the other judges here. What, uh, what would happen to the MOG antibodies in a patient who is breast cancer patient or a patient who has been treated for a breast cancer? Because all these are immune related, number one. Number two is there is an entity called paraneoplastic optic neuropathy.
Yes, sir.
So, would this be that?
No, actually, sir, we had investigated in the blood investigations also. We had investigated for paraneoplastic antibodies, which also came negative in this patient.
Okay.
So that was also there in the blood investigation. So that was negative.
Fine.
Classical of MOG, because in MOG you get demyelinating plaque,
Yes, ma'am.
and then you get fat stranding.
Yes, ma'am.
That is supposed to be in the MOG MRI. You know,
Yes, ma'am.
I think it's nice presentation.